Hi, my name is Brett Shore. As Dr. Banfi mentioned, I am the head of hip preservation for the Kaiser Southern California Permanente group. And we're going to talk a little bit about arthroscopic management of hip pathology in general. We're going to do a tour of sort of the things that we can treat and a review of the literature. So it's going to be a bit of an overview. Disclosures, I have nothing to disclose because I work for Kaiser. Hip arthroscopy. So hip arthroscopy has evolved significantly from the early days of loose body removal and labral debridement. Orthopedic conditions that are amenable to arthroscopic treatment now include, but aren't limited to, FAI, greater trochanteric pain syndrome or hip bursitis, hamstring tendinopathy, deep gluteal space syndrome, also referred to as piriformis syndrome, ischiofemoral impingement, and assorted other pathologies around the hip. Sorry, trying to advance. It's not. Can you pause for a second? It's not advancing now. Sorry. What the heck? All right. I'm ready to go again. Femoroacetabular impingement. So this is the most common reason for hip arthroscopy and hip preservation surgery in general. What is FAI? So FAI is, at its base, essentially a mismatch of the radius of curvature of the femoral head-neck junction and the acetabulum. Why is FAI a problem? Well, the biggest reason that it's a problem, and I'm going to go over this quickly because I think most of the people who are listening are familiar with the basics of FAI. Basically, FAI is a problem because it causes damage to the acetabular labrum, chondrolabral junction, and acetabular cartilage, which eventually leads to arthritis. Additionally, the majority of hip arthritis, over 90%, comes from morphologic abnormalities of the hip, either dysplasia, too shallow a socket, or FAI, which is essentially too constrained a socket. And these can sometimes occur in the same patient. What can be done about it? Well, treatment options include conservative treatment, cortisone injections, anti-inflammatories therapy, and surgical treatment. Additionally, the role of physical therapy in FAI, although we frequently prescribe it for patients, it's not really well defined. The better question, or the more important question I should say, is not just what do we do, but does it work? So because the field of hip arthroscopy has expanded so dramatically, there have been a lot more studies recently about outcomes in hip arthroscopy. There have been a couple recent systematic reviews. This systematic review covered almost 2,000 patients with a mean age of 30 years old. And they found a low reoperation rate of 5.5% and a very low complication rate with an 88% return to sport and significant improvements in all patient-reported outcomes. Another meta-analysis, which was done of randomized controlled trials comparing operative versus non-operative treatment of FAI, found greater improvement of patient-reported outcomes in surgical patients in all but one study. Furthermore, the one study that reported MCID and past data showed that a significantly greater number of patients achieved what would be considered an acceptable level of disability with surgery than without, again, suggesting that surgery for FAI is an effective treatment. What about long-term outcomes? So we haven't been doing this operation long enough to have a lot of really good long-term data, but this study by Dr. Dome found in patients under 50 with a mean follow-up of over 5 years that the average decrease in digital analog pain score was 3.5. They all had improvements in their patient-reported outcomes. The revision rate is interesting to note, though, because he had noted a revision rate of over 11%, which is something we should probably keep an eye out for as we follow our primary hip arthroscopies longer. What about hip arthroscopy in specific patient populations? So in the setting of borderline hip dysplasia, which is another situation in which patients tend to develop labral tears, hip arthroscopy has been utilized. This study found that in terms of looking at the outcomes, they found overall good results in patients with borderline hip dysplasia, which is defined as a lateral center edge angle between 18 and 25, that were not significantly different from from the control group of patients with normal center edge angles. In this study by Dr. Dome, again, looking at hip arthroscopy in the setting of borderline hip dysplasia, specifically looking at predictors of failure, what this group found was that the most important predictors of failure include age, tonus grade greater than 1, which of course makes sense because that's pretty significant arthritis, and then tonus angle. And this is an important thing to consider when determining who's a good candidate for hip arthroscopy, because I've taken some of this in terms of my indications, such that once I have determined that a patient has an acceptable lateral center edge angle for hip arthroscopy, which would be about 18, 19, then the bigger issue is the tonus angle, because a patient with a tonus angle of 9 is much more likely to do well than a patient with a tonus angle of 16. As you can see, with a 15% higher failure rate for each 1 degree higher in tonus angle, it's a pretty significant effect. Other patients with borderline dysplasia, again, this was another study by Dr. Dome, looking at the success of treatment for borderline hip dysplasia with capsular plication. These patients overall also did well. However, they found that predictors of failure included lower pre-op patient-reported outcomes, higher pre-op visual analog pain scores, and increased age. Pretty much the same predictors of failure that almost all of these studies have. What about revision hip arthroscopy? Because we're doing so many primary hip arthroscopies now, there's going to be a lot more revisions to be done in the future. This was a study out of Chicago by Dr. Shane No and his group, looking at the outcomes of revision hip arthroscopy for capsular insufficiency, which is an entirely iatrogenic problem when hip arthroscopy is performed and the capsule either is not managed properly or is but still fails to heal. And what their group found was that revision for residual FAI and residual for capsular management both had similar outcomes and both showed significant improvements over preoperative, over the patient's preoperative condition. However, the results for both were significantly worse than what is seen for in primary hip arthroscopy, which again is consistent with previous studies on revision. This was a study where Dr. Philippon looked back at the revisions that he had performed in his practice in Vail. And again, what he found here was that he actually found a lower revision rate in the revision group, both groups showing significant improvements in patient-reported outcomes. And again, as expected, the predictors for better results from revision include no labral retear. In other words, the problem was its adhesions or some other or capsular problem, and residual joint space. And then finally, moving on to arthroscopic labral reconstruction, which has taken a more prominent role in my own practice as well. This was a study looking at the 5-year results of labral reconstruction, basically finding no statistically significant differences between the repair and reconstruction groups. However, they did find that reconstruction groups seem to have lower patient satisfaction scores, and it's unclear why that would be the case with the reconstruction. These two studies were both by Dr. Brian White, who has popularized the circumferential labral reconstruction. And he found in both his side-to-side comparison of repair versus reconstruction and in his case series of reconstruction, much, much better results in reconstruction versus repair. The one thing to note about his studies, though, is that his revision rates and failure rates for repair are significantly higher than what most other surgeons are reporting. So that has to be taken into consideration when interpreting this data. But overall, I would say in my own practice, I have been doing more labral reconstructions as well, and longer reconstructions to reduce the need for anastomosis between the native and reconstructed labrum. So we're going to move on to some of the other problems that you can treat arthroscopically in the hip outside of FAI. The next most prominent problem is greater trochanteric pain syndrome, frequently referred to as hip bursitis. This includes lateral-sided hip pain from bursitis, partial and full thickness tears of the gluteus medius and minimus, and external snapping hip. So first, a brief review of the anatomy. The peritrochanteric space is the space between the iliotibial band and the glute medius. The glute medius originates from the iliac crest and inserts onto the greater trochanter with two distinct attachment sites, and this is important for to remember for repairs. The two attachment sites are the lateral facet and the posterior superior facet, and there is in fact a bald spot, which you need to be aware of, which is analogous to the bare area of the rotator cuff, and where no glute medius should be attached. Again, this is just a summary of some of the analogies or analogous structures between the rotator cuff and the hip. This is just a quick review of the anatomy, piece by piece. So in terms of how greater trochanteric pain syndrome presents, most of these patients present in their 4th to 6th decades of life, primarily with lateral sided hip pain, pain lying on their side, and tenderness over the greater trochanter. The other thing to look for in these patients is you should have all patients walk to watch their gait, but these patients in particular, because you want to identify if they have a Trendelenburg gait. Next question, do the treatments work? That's sort of the theme of this talk. It's easy to go over all the things that we do, but the more important question is, are we making patients better? So most patients with greater trochanteric pain syndrome can be treated conservatively with physical therapy, anti-inflammatories, and injections. There's also been some data showing benefits from shockwave therapy, and there's even a randomized study looking at the results of PRP versus corticosteroid, and it did show higher modified Harris hip scores in the PRP group. So in terms of surgical treatment, because that's what we're mainly here to discuss, there have been several studies reporting the results of surgical treatment of trochanteric bursitis. Fox, Weiss, and Baker all reported overall good results in this patient population. The most interesting finding, I think, from these studies was that Baker's paper describes identifying a number of gluteus medius tears. He didn't repair any of them, and they just debrided them, and somehow these patients all did well, which is impressive. Greater trochanteric pain syndrome also can refer to external snapping hip. The endoscopic technique was originally described by Ilizaturi in 10 patients with 100% pain relief and 1 instance of recurrence. A larger systematic review in 2018 found that surgical treatment for external snapping hip had a recurrence rate of 7%. Now, this did include both open and arthroscopic treatment. And in my own experience, I have had 1 recurrence, which was successfully treated with revision to an open IT van windowing. What about glute medius repair? Does it work? Well, one of the earliest reports on this was out of New York, where Dr. Voos out of Brian Kelly's lab group reported on the results of glute medius repair in 10 patients. They all somehow did great. Honestly, these are some of the best results I've seen for glute medius repairs. Additionally, another one of the earlier studies was out of Brigham and Women's Hospital with Dr. Scott Martin, reporting on the results of 10 patients with endoscopic repair of full thickness tears, overall with very good patient-reported outcomes and high patient satisfaction scores. This was a slightly larger study by Dr. Dome's group, reporting on the results of abductor tears. There were sort of 2 separate subsets within this group. Half of the patients had a transtendinous partial repair and half had a double row full thickness repair. These patients all had significant improvements in the visual analog pain scores with 58% normalized gait and no re-tears. However, 4 of these patients did go on to a hip replacement at 16 months. And one other important thing to consider with this paper is that it is a mixed cohort, and all of these patients also had intra-articular pathology that was addressed as well, as evidenced by the fact that 4 of them went on to total hips. Next, we'll move on to briefly discuss piriformis syndrome, deep gluteal space syndrome. So this basically refers to compression of the sciatic nerve by either the piriformis tendon, fibrous bands, or other abnormalities, occasionally vascular malformations, which can occur there as well. These are a couple examples of the anatomic variants of the piriformis tendon and the sciatic nerve, which have been described. And on the right, you'll see, actually, that's an intraoperative photo from one of my own cases, where this patient did have the early split of the sciatic nerve. This patient did very well postoperatively and unsurprisingly failed conservative treatment. So how do we diagnose piriformis syndrome? Because that's really the key. Really very important to be very, very selective in who you operate on. In 8 years, I've probably done 10 of these operations. No, less. Probably more like 7 or 8. So how do we make the diagnosis? Some of these patients will have had trauma to the gluteal region. The inability to sit is actually one of the best diagnostic findings. I'd say every single patient that did well after the surgery that I operated on, when I came into the exam room, they weren't sitting. And that is a consistent finding. Tenderness over the piriformis, and especially reproduction of pain with the either fair position or the seated piriformis stretch test. I have found the seated piriformis stretch test to be the most reliable and reproducible, at least in my own hands. And in terms of the literature, most patients can do well with non-operative treatment. You can also selectively inject Botox into the piriformis. I've occasionally had patients get anesthetic or cortisone injections, largely for diagnostic purposes to help confirm the diagnosis. Because we don't have anyone who will do Botox injections at our institution. So in terms of literature review, there's not a lot written about this, but the largest series and the person who's popularized this the most is Hal Martin out of Baylor. And his series of 35 patients with a minimum 12-month follow-up found that the most common symptoms the patients presented with were sitting pain, night pain, and radicular pain. And these patients had very significant improvements in all of their PROs, despite long duration of symptoms with a mean time of almost 4 years. And these are just some examples of what the sciatic nerve can look like before and after decompression. And then finally, we'll move quickly through hamstring pathology. Hamstring pathology, which can be treated endoscopically, includes severe tendinopathy, partial tears, and complete tears with minimal retraction. Large retracted tears are still probably better to repair open, although people with a lot of experience with this technique will be able to do some of these arthroscopically, especially in the acute setting. So again, a brief review of the anatomy. The common hamstring origin is approximately 4 centimeters lateral to the ischial tuberosity, and this is important to note. A recent anatomic dissection out of a group here in LA, actually, Dr. Gerhardt's group, did not show distinct hamstring origins. Instead, it found that the separation didn't occur until 1 centimeter or 2 off of the pelvis. And additionally, that the hamstring origin was actually 3 to 4 centimeters proximal to the ischial tuberosity. The reason this is important is from a technique standpoint. If you reattach the hamstring to the ischial tuberosity, patients much more likely to complain of sitting pain postoperatively. How do these happen? These tend to occur as a result of eccentric loads via hip hyperflexion and knee extension. Exam findings: tenderness, ecchymosis, sitting pain. Some patients will describe sciatica symptoms as well. Conservative treatment. This is largely an operative problem if it's an acute injury. A conservative treatment is appropriate for partial tears, complete tears with minimal retraction, patients who are poor surgical candidates, and as treatment for chronic tendinopathy. Open repairs is still my preferred technique for complete tears with significant retraction, but endoscopic repair is a good technique for the partial tears and for minimally retracted complete tears. So in the literature, some of the studies that have been done following the results of endoscopic proximal hamstring repair overall have found very good results with high rates of return to work. But interestingly, better results in patients with complete tears versus partial tears. And the most common complications, as expected, were sitting pain and subjective hamstring weakness. There was a biomechanical study recently performed looking at endoscopic hamstring repair, actually out of the American Sports Medicine Institute, which is where I did my training, by Dr. Emblem, who I learned how to do hip arthroscopy from. Basically trying to look at 2 questions. 1, how safe are the portals for hamstring repair? And 2, how robust is the repair achieved arthroscopically? And what they found was that all of the portal sites were a minimum of 2 centimeters away from the sciatic nerve, with the superior lateral being the closest. And the biomechanical testing showed no significant differences in ultimate load, strain, or displacement at time of failure between endoscopic and open techniques. And then finally, this was a large series, retrospective review of hamstring repair, mixed techniques, both open and arthroscopic, out of Dr. Banfi's group. at Cedars-Sinai and with Curl and Job, where they looked at 58 patients who had hamstring repair. 78% were complete avulsions, 90% had open repairs. Very high overall satisfaction rate of 94%, 88% returned to sport. But what was very interesting about their study was they found that runners did worse, both in terms of their overall patient satisfaction and in the percentage of runners who returned to their pre-injury level of running. Additionally, they found a 15% complication rate, and that, much like the earlier study we referenced, acute tears tended to do better than chronic tears. And that is hip arthroscopy in a nutshell.
Thanks, Brett. Excellent talk. Just a couple of questions. First of all, just for the general orthopedists out there that are not doing hip arthroscopy frequently, you know, we often will see cam impingement on X-rays that may be taken for some other reason, or you have a patient that has a symptomatic labral tear, symptomatic impingement on one side but not the other, even though radiographically it looks that way. How do you feel about treating this prophylactically? We know that the cam lesions can cause cartilage damage, but is this something that you think we should be playing around with?
It's a really good question, Dr. Banfi. And to be totally honest, it's still something I go back and forth with. I think the problem we have in hip arthroscopy is that we haven't been doing it long enough to be able to prove what we think we already know, which is that this helps prevent arthritis. We do this operation for two reasons. One, for the short-term symptomatic relief, and two, for the long-term prevention of hip degeneration. And even though we believe that that is what we're doing, I think because I am not any good at getting asymptomatic patients to feel even better, it is still my practice that until a patient develops symptoms, even if they have a cam lesion, I will not offer them surgery, but I will offer them surgery the second they start having symptoms.
Yeah, that's how I approach it as well. And then lastly, what's your role and how do you like to perform diagnostic injections in your practice?
Again, that's also a good question, because there have been a couple studies recently calling into question really how important they are. In my practice, I have a unique setup because I don't have like a family practice like ultrasound person, and I haven't had a lot of experience doing ultrasound injections. So I still do most of my injections under X-ray. And then what I'll do is, if it's a patient where I'm pretty confident in the diagnosis, then I'll frequently do the injection with cortisone, anesthetic, and frequently the gadolinium, and send them to get the MRI all in one injection. But if I'm really not sure about the diagnosis and I really want a very good diagnostic test, then I will do the injection separate from the MRI, from an arthrogram injection, because I found that at least a small subset of patients seems to be very sensitive to the gadolinium, and it can give you sort of a false negative on their injection. So that's usually my practice. And I do inject most patients. I will say that when I see like a 19, 20-year-old football player with a giant cam lesion and no internal rotation, I generally skip the injection on those patients unless they really want it, because I'm pretty confident. But in general, that's usually how I go about doing it. I think for a lot of patients, especially over 40, I really almost want to inject all of them.
All right. Well, great. Thank you very much. That was excellent.